Okay.
Okay, it looks like everybody's on and can hear now, so we'll get started. Today, we're very fortunate to have Dr. James Chow joining us from the Northeast Geriatric Services out of Sudbury. As many of you will know, he is a very valued member of our team here in Parry Sound when he comes, and he serves a lot of our patients. And he's going to speak to us about psychosis in the elderly. Oh, and just one last thing, he is willing to be interrupted if you have any burning questions in the moment. Go ahead.
Yeah, I had to find my unmute button again to unmute myself. So thank you, Kathy, for the invitation to speak today and for the introduction. And thank you for putting up with me. I was looking back, it's been 10 years now. I think you've had to put up with me doing the telemedicine stuff. So thank you, Kathy. So I'm going to spend the next little bit talking about psychosis in the elderly, often an topic that can be difficult to navigate. So hopefully we'll be able to make a bit of sense of this as we move forward. So the requisite disclosures, not really any commercial interest associated with this talk, and no commercial support other than when I did the first iteration of this. I had a stipend from the Northeast BSO. I had done a similar talk for them on that. I do have the disclosure that I'm a Montreal Canadiens fan when it comes to hockey, so maybe that in some people's eyes will discredit me off the bat, but I hope not too much. I'm going to be running some polls through the course of the talk today, and this is just a fun one just to get folks started. You can either join by pollev.com/NESGC, or there's a QR code in the corner. You can scan that if you want to connect you to the poll. And I'll just have a couple of these polls through the session, not too many. Tried not to overdo it. Give folks a try to see if it works out. If not, you're also welcome to just throw the stuff that comes up on the polls on the chat as well. If you want to do that, you're welcome to do that as well if you have trouble linking on to these polls. So far, it looks like it's, oops, whoa, I did that. Oh, sorry. I did what I wasn't supposed to do. I scrolled by accident. Okay, so I'm hoping that kind of worked out for folks. We'll have a couple more of these polls as we go along. All right, so I do want to acknowledge the library staff at Health Sciences North. They're so patient with me when I'm sending the request to track down articles and whatnot, and always very efficient in pulling the stuff that I need. And then also have to acknowledge my family all the time when I do these talks, because it means when I'm prepping for the talk and stuff, I'm ignoring them. Maybe they're happy with that. I'm not sure, but I did want to acknowledge them as well. Now, so for the session today, hoping to touch upon a couple of areas, looking at firstly at some of the diagnostic features that might help distinguish between the various causes of psychosis in the elderly. We'll spend some time looking at the role of medications in the management of psychosis, and then propose a framework approach that one could take and when you're tackling psychosis in the elderly. So those are sort of the three objectives I'm hoping by the end of the session that we'll have a chance to go over. And another disclosure, of course, is the approach I'm taking is not from a psychiatrist or a geriatric psychiatry standpoint. So to keep that in mind. Okay, so I've structured the session today, I don't know, for some reason, and in how a symphony usually goes, there's an opening to the symphony, then there's a couple of movements, and then the finale. So I've sort of structured it that way. So we'll start off by going through some cases. And probably in those cases, you'll see some things will probably strike you as being familiar in your day-to-day practice. And then we'll move on to look at some of the definitions, look at some of the diagnoses where you'll see the psychosis symptoms, and then we'll spend a bit of time talking about management and the role of medications, and then we'll wrap things up looking at the approaches and how to evaluate treatments. So that's the game plan. So we'll start off with the first case then. These are all folks that I've seen within the last 6 months to a year. So this is a 86-year-old gentleman, hails originally from Germany, completed grade 6 level education, subsequently later in life took some theology courses, a really hard worker, worked in housekeeping, mining, sales, and then the last, I think, 15, 20 years of his life operated a carpet store with his spouse. His spouse now was diagnosed with dementia a few years back. She's actually in a nursing home currently. His main caregiver is his son. Unfortunately, he's estranged from his other 3 children, so his son's the main person in his life, and the 2 of them live in an apartment complex. So in his situation, what's happening, he's been experiencing these hallucinations, auditory hallucinations mainly. And it started off where he would hear German folk songs. He'd hear a lady and a man singing these traditional German folk songs. And it was actually a pleasant experience for him. He didn't mind it at first. And he would describe the music as coming through a PA system or a loudspeaker. Unfortunately, this music sort of then shifted to this lady and man now hurling insults and accusations at him. And then they went from that to starting to narrate his actions. So day to day, almost like a play-by-play of whatever he was doing, they'd be commenting on it in the background. And things sort of culminated in a situation where he was in the common area kitchen of the apartment complex, and he ran to get the superintendent, telling the superintendent there was a man bleeding on the floor. He was all distressed and upset. And of course, when the superintendent came, there's nobody there. There's nothing at all in the kitchen. And in general, the trend was these hallucinations would become more intense or more frequently occurred in the evenings. And looking in his background, there's been concerns with his memory now going back about 10 years. He was actually diagnosed with mild cognitive impairment back in 2012. During a hospital stay in 2021, he was formally diagnosed with a major neurocognitive disorder. He's had a number of hospital admissions over the last couple of years for attempted overdose, adjustment disorder, depression. And when we dug a bit deeper in the background, there's actually been legal issues that have been flagged surrounding a possible sexual assault of his daughter and a granddaughter. And this was an area that he never wanted to talk about. He's actually been on treatment with one of the cholinesterase inhibitors, donepezil, for the past 10 years. And looking back at his pharmacy record, at one point he was on escitalopram, so one of the antidepressants as well. And with the things that have been happening now, the landlord's questioning whether he's actually safe to stay in his apartment, and they were talking about possible eviction. So that's his situation. So that's the first case. And then the second case, a 67-year-old gentleman born and raised in the Sudbury area, has lived there all his life. He completed 2 years of college, worked initially at the Domtar mill and then subsequently at Xstrata as a stationary engineer. He went on a disability pension because of his diagnosis of Parkinson's. He's married, lives with his spouse, and his spouse actually took an early retirement so she could support him at home. He has 2 sons, both out of province, and he's in regular contact with just one of the 2 sons. And his situation is, it started off with him seeing shadows, thinking that he's seeing some movement or person or possibly an animal out of the side or corner of his vision. And the last couple of months, this has sort of shifted to him looking out the window and thinking there's somebody staring back, looking into the house. And the couple have a frosted sort of glass door. And so he's thinking he's seeing somebody standing on the outside, also trying to look in through that frosted glass of the door. And then things shifted where he would tell his wife that things are going missing in the home, thinking that these people are coming in, breaking in and taking things. And then the most recent thing was him telling his wife always to check on the toilet, on the taps, thinking that he hears the toilet running or hears water dripping. And again, these were symptoms that would occur more frequently, more intensely as the day progressed. So his background is Parkinson's disease, as I mentioned, for about 10 years, over 10 years now. And in the last year and a half, through his neurologist, his levodopa carbidopa, so the Sinemet dose has actually been turned up quite a bit. He's on about 13 tabs now total of the levodopa carbidopa, spread out 5 times through the day. And he was diagnosed with a major neurocognitive disorder associated with Parkinson's disease about 4.5 years ago. And he's actually on treatment already with the rivastigmine patch, so one of the cholinesterase inhibitors. So that's the second case. And then the third one involves an 85-year-old lady, hails from Ukraine, originally at one point lived out in Saskatchewan. From what we were able to gather, she completed grade 12 level education. She wasn't very forthcoming about her personal history, but other than saying she did odd jobs, she apparently was married for just the 1 year, divorced, has no children. She's lived alone in the same bungalow now in town for over 20 years. She has a small circle of support. A couple of friends in the neighborhood will help her out, help her, bring her to do her groceries, to go to the bank, that sort of thing. She talks about a brother and a sister who apparently are still living. Not sure how often she's in contact with them, but it sounds like they're both out of town. So that's her situation. And in her case, from the very first encounter, she's very suspicious of healthcare providers in general, and also suspicious of medications, any type of prescription medications, saying that the doctors want to give you pills to kill you when you're old. That was something that she would come back to. And then she would also say that nobody's doing anything to help her. She also harbors these worries that things are going missing in her home. And she's actually accused some of the immediate neighbors of breaking into her home and stealing things. So she's alienated several of the neighbors. And in her situation, we suspected that there's probably some cognitive changes. She's never agreed to do any type of testing. And functionally, she seems to be managing in her home setting, but we have no sort of corollary or supportive history at all. And for the longest time, she didn't want any type of follow-up or healthcare providers coming to support her. We show up at the door and she'd turn us away. We'd call, try to book an appointment, and it would never be a good time. And that's why we started just drop-in visits. So that's her situation. So those are 3 cases. I'm hoping that there's some sort of familiar features that folks may have come across or have dealt with. Keep those in mind. We'll sort of move on and then come back to them at the end. So in terms of our second movement now, we'll spend a bit of time talking about some of the definitions and some diagnoses. Brings us to our next poll here. So again, the question is, what is psychosis? What's your understanding, or what's the working definition of psychosis that you use in your day-to-day practice? You can scan the QR code to do that, or go to pollev.com/NESGC. I'll give folks a little bit of time to respond to that. And you can also feel free, if you want, to just throw your answer in the chat as well, and I'll keep an eye on that. Also, if that's easier for folks. I'm doing this poll stuff, and you never know how well it's actually going to work. In theory, it sounds good, but a couple of responses coming in. So alter the thought process from the norm, loss of contact with reality, out of touch with reality. Okay, a change from awareness. Okay, good. So great. All right. Good. So I think folks are really capturing a lot of the key features of psychosis. Okay. Right. Wow. Okay. So the polls must be working. The answers are coming in. Okay, great. Thank you. Thank you, everyone. Okay, so we'll move to let's actually look at the definition. So if we're looking at sort of a dictionary definition of it, the psychosis is from the Greek derivation, abnormal condition of life, soul, and mind. And sort of a working definition is loss of contact with reality. So several folks had come up and focused on that detachment from reality. If we look more from the mental health standpoint and how the DSM-5 sort of captures psychosis, they sort of highlight these areas, right, which were sort of brought up also in what the folks had submitted with the poll: delusions and hallucinations, right? But also can include disorganized thinking, including disorganized speech. Abnormal motor behavior can be part of that, whether it's sort of unusual type activities that somebody might do. It can be doing lots of activity, or the opposite, where you're catatonic and doing very little. And there can be sort of negative symptoms too. So loss or a reduction in some of that normal day-to-day function in people. So that's sort of more from a mental health standpoint and how psychosis would be defined and outlined. So when we look at some of these conditions and diagnoses that can be associated with psychosis, obviously there's the schizophrenia. And we know, of course, there's folks who may develop it earlier in life, but there can be a categorization of folks who have very late onset schizophrenia. So after the age of 60, where they have their first presentation, tends to be more females than males. And in terms of the psychosis features, visual, olfactory, and tactile hallucinations, and you can get more persecutory or partition type delusions. The partition delusions where people can sort of come through a door, a wall, or window, passing through almost like a ghost type thing. And there tends to be less of this formal thought disorder or negative symptoms with the very late onset schizophrenia. So that's one of the diagnoses where you might see psychosis. And of course, there's delusional disorder, defined by sort of one delusion, a person having one delusion, this fixed false belief for at least 1 month. Usually there's no significant functional impairment or bizarre behavior associated with it. And again, you can categorize it as the late onset, those over 60 years old developing this. And there's concern in terms of confounding factors, or what might muddy the waters in this, is if they have vision or hearing impairment. So there's schizophrenia, there's delusional disorder. And then, of course, we know depression or psychosis or psychotic depression can be associated clearly with psychosis, as well as the name would suggest. The depression tends to be quite severe, and in seniors who have a psychotic depression, you can get mood congruent delusions. So these nihilistic type delusions where they think part of their body is not working or that it's rotting, that type of thing. You can have a lot of physical symptoms, hypochondriasis, and somatic delusions. So thinking they have some type of illness or something like that. And then auditory hallucinations. If you do have hallucinations, it tends maybe to be auditory hallucinations in the psychotic depression. So schizophrenia, delusional disorder, psychotic depression. And then clearly we can look at the group of the dementias, right? The major neurocognitive disorders, and probably most often in practice, this might be where we might come across folks experiencing psychosis. There's visual or auditory hallucinations, and delusions are common as well. And the International Psychogeriatric Association actually came up with new updated consensus criteria in 2020, saying that you do have to have either visual or auditory hallucinations or delusions, or both. There has to be that diagnosis of cognitive disorder, neurocognitive disorder. It could be an actual dementia, like a major neurocognitive disorder, but could also be mild. So you could have MCI, mild cognitive impairment, or mild behavioral impairment, and it could still fit in this definition. And the onset of the psychosis has to be clearly after the diagnosis of the dementia. It has to be present for a month or more, and in some way it impairs function or raises safety concerns. So that was the sort of working definition the Psychogeriatric Association came up with. If we look at the specific types of neurocognitive disorder dementias, with Alzheimer's disease, tend to be hallucinations. If they do have hallucinations, it tends to be visual. There can be a lot of paranoid type delusions or misidentification. So thinking their spouse is somebody else, like their daughter or aunt or their mother, that type of thing. Delusions of theft are common, but also delusions of spousal infidelity, thinking their spouse is having an affair, or thinking that they're going to be abandoned or left somewhere. And the severity of the psychotic symptoms tend to progress with stage. So the more advanced they are, the more severe the psychotic symptoms tend to be. So that's with the Alzheimer's disease with Lewy body type of dementia. We know one of the core features is hallucinations, right? And the hallucinations in folks with Lewy body tend to be very vivid, and they're present very early on in the disease process. Misidentification delusions are also common, and probably more common than you would see in Alzheimer's disease, and the severity is also stage related. So that's Lewy body. So a couple of words about Lewy body. And I didn't want to forget about the other, these two other types of dementia where you might also see psychosis. So in vascular dementia, and it's pretty much a brain lesion dependent, depending where in the brain you're compromised more. The psychotic symptoms will be a bit different. And then in folks with frontal temporal or FTD dementia, delusions tend to be more common, but you can also get hallucinations in some. So I wanted to spend a little bit of time speaking about Parkinson's disease specifically, because there's a bit of overlap with the Lewy body dementia. You can get visual hallucinations again. They tend to be very vivid and clear. Most of them are non-threatening and brief, like the gentleman we talked about in the case initially could have these presence or passage type hallucinations. So presence is the sensation that somebody is nearby or somebody hovering or looking over your shoulder type thing, and the passage type hallucinations where out of the corner of the eye think there's somebody walking by or an animal's passing by. So that type of hallucination. The hallucinations can become more distressing, complex, and upsetting as if they have a concurrent diagnosis of dementia, so Parkinson's and dementia, then the hallucinations can shift to become more distressing. And in general, with Parkinson's disease, delusions tend to be less frequent. If they do happen, they're often the persecutory type, where they're feeling that somebody's monitoring or watching them, or that somebody's out to cause them some harm. You also can get misidentification, especially if they have dementia concurrently. And then we have to remember in Parkinson's disease that sometimes the medications can make these symptoms worse. The dopamine agonists in particular, so we're talking ropinirole and pramipexole. So those as two examples of Parkinson's meds that can actually make the psychosis worse. And then there's the whole group of secondary psychoses, so other medical conditions and whatnot that could contribute to psychotic symptoms. So either using substances like alcohol, cannabis, stimulants, sedative hypnotics, they can all cause sort of induce psychosis, either when you're taking them or when you're withdrawing from them. And then of course, delirium. We know that often delirium, when we see folks, especially in the hospital, that you can get these associated psychotic features as well, right? And then they've listed a few other conditions there where that can be also associated with psychosis. And certainly in the last few years with COVID, we know COVID can have an impact on the brain, cause cognitive impairment, and there have also been cases of psychosis that have been documented in folks with a COVID infection. Okay, so those are the secondary causes of psychosis. Now, we've walked through a whole bunch of sort of these possible diagnoses that can be associated with psychosis in the elderly. So this next poll is one that you can order. You tap on it and tap on each selection, and then it allows you to move it up and down. And so this is sort of an ordering one, which one you think is most common or most prevalent, and which one you think would be least prevalent in the elderly. So I hope it's not too complicated to do. Kathy and I were fooling around with this earlier to make sure it actually worked. So hoping it works for folks. So this one, you can just order them, move with the up and down arrows. give folks a little bit, and then we'll see what folks are thinking. Shift over and just see where the people's thought process are. Okay. All right. So it looks like the runaway is a major neurocognitive disorder, and we're having a battle between delirium and depression. And they're going back and forth. Looks like it's a tight race between those two Ds. So it's actually the three of the Ds up there, right? At the top. Okay. Okay, great. So major neurocognitive disorder at the top, delirium, depression, schizophrenia, delusional disorder. I think you guys are bang on, actually. So when we look at the breakdown and how common the diagnoses tend to be, so I think folks are right that major neurocognitive disorder is by far the runaway in terms of where we would most commonly in practice see the psychosis in seniors. And then we have the secondary causes, right, where there's delirium and substance use. And then a bit further down, so it's a fair bit of a drop off. So these top three would by far account for most of the cases. And then there's a drop down to the sort of mental health diagnoses, depression, schizophrenia, delusional disorder. Okay, so that's usually in practice sort of the prevalence of the psychosis related diagnoses in the elderly. Okay, so we'll spend now some time after running through all those diagnoses and some of the features. We'll spend some time now looking at management and the role of medications. Looks like I'm doing okay with time so far. And Kathy's not giving me that look yet, so I'm okay. In terms of the management, then of course there's always the non-pharm, to remember always starting off the non-pharmacological interventions. We mentioned a bit earlier already, vision and hearing and how that can complicate the situation. So you would want to make sure those are optimized. I put the pieces, for those who are familiar with pieces, that's derived from the behavior management in folks with dementia, where you're looking at all the physical, intellectual, emotional, cognitive, environmental, social, spiritual factors. So all the different factors that might be impacting a person, just a reminder to look at the big picture. And then not to forget in terms of the importance of supporting the care partners, because they're going to be on the receiving end and having to deal day in, day out with the psychosis symptoms and the fallout, and then providing education as well. So just some general principles from the non-pharmacological management perspective. And looking at specific interventions, most of this comes from the literature on folks with schizophrenia, where they know that cognitive behavioral therapy, social skills training, there may be some role in that. In folks with mainly living with dementia and long-term care, exercise has been shown possibly to have some benefit. There's been a lot of interest looking at music therapy, again, in the dementia folks living with dementia population, possible benefits that might have if they are experiencing psychosis. And we know that ECT is one of the staple interventions in treating depression with psychosis. It's also been used in folks with schizophrenia as well. And then there's the transcranial magnetic stimulation, deep brain stimulation. Those two have been used in treating depression with psychosis in the elderly, but the main outcomes in those trials were looking at mood and not so much the psychosis symptoms specifically. And deep brain stimulation, so the DBS, we know in patients with Parkinson's, sometimes that can actually precipitate psychosis. Okay, so the deep brain stimulation might actually make it worse. We'll go through now in terms of some of those diagnoses we talked about earlier and the role of medications. We know in schizophrenia, in the very late onset schizophrenia patients, the atypical antipsychotics would be your standard sort of interventions. In terms of the dose ranges, in general, they're a bit higher than typically we might use in a patient with dementia, or we might be familiar with. So a bit on the higher end dose range wise. And there's actually no clinical trial data to support the use of these, and it's mainly from years and decades, I guess, of expert consensus and experience in terms of the medications you might consider in the very late onset schizophrenia. And delusional disorder, we know often is very difficult to manage and treat. And the medications probably most commonly leveraged. You can use really any of the atypical antipsychotics. In terms of evidence-wise, again, there's very little. So a lot of it comes from expert consensus again. Risperidone, either oral or IM, and then the paliperidone, which is the Invega IM, the injectable form, are two that can be leveraged in the context of delusional disorder. And psychotic depression, we already mentioned the role of ECT. And again, the use of ECT, of course, is, again, difficult to run clinical trials in this context, right? So most of the recommendations are based on expert consensus again. And in terms of medications, combination of antidepressant, atypical antipsychotic, right? I think that's usually the generally accepted sort of approach from the medication standpoint. And again, there's not a whole lot of randomized controlled trial level literature to support that. But that's I think the standard treatment and intervention. So that's for psychotic depression or depression with psychosis. Alzheimer's disease and psychosis associated with Alzheimer's disease. This is one of the areas where we do find a bit more literature to support sort of medication use. There's some studies indicating that citalopram, we know citalopram is one of the medications that have some literature to support its use in treating agitation in folks with dementia, but also psychosis in that dose range, 20 to 30 milligrams. Any of the atypical antipsychotics, and we know in practice, there's a range of them that will be leveraged or used. There is some clinical trial data and some meta-analyses looking at these that we know risperidone is one that can often be used in that sort of dose range, 0.25 to 2 milligrams. Really, quetiapine, olanzapine, aripiprazole, or other ones I'm sure folks may have come across as well. And I put the aripiprazole out there because there are some expert psychiatrists who are now leaning a bit more towards the aripiprazole because of just the drug profile and thinking that maybe in certain circumstances it's a bit safer side effect wise. But all of them have this black box warning, right? All the atypical antipsychotics, using them in folks with dementia, there's the potential that it could increase your risk of stroke and death, right? Looking at the absolute risk increase is about 1%, right? Risk increase using them in the context of someone with dementia. So that's medications from the standpoint of Alzheimer's. In Lewy body, there's evidence to support using a cholinesterase inhibitor, particularly donepezil, the 5 to 10 milligram range. You can also use the low dose atypicals, the olanzapine, quetiapine, aripiprazole, or clozapine are all ones that have some evidence and have been studied. And again, in terms of side effect profile, oftentimes the ones you end up using are quetiapine and then possibly the aripiprazole as well, just in terms of the safety profile and the side effects. So that's Lewy body in a quick snapshot. With Parkinson's disease, often the first step you take is looking to see whether you can reduce some of the Parkinson's medications. If they have psychosis, particularly if they're on something like one of the dopamine agonists like pramipexole or ropinirole. So you'd want to dial that back first if you can. In terms of actual treatments, the cholinesterase inhibitors again, so the dementia meds, rivastigmine and donepezil. Some studies looking at that in terms of being effective for psychosis. In terms of the antipsychotics, the one that probably has the best evidence support-wise is the clozapine, but in practice difficult to use because there's a risk of agranulocytosis, so you have to do regular lab work and monitoring. In the States, they had the pimavanserin that was approved, and not approved yet in Canada. So whether that will be at some point, I'm not sure. In terms of practical sort of standpoint, again, quetiapine or Seroquel is probably the one most folks are familiar with being used to treat psychosis in Parkinson's disease, just in terms of the low risk of extrapyramidal symptoms. So that's Parkinson's. And then in terms of the medications, I think we're always need to be aware of side effects, right? Especially when we're using these atypicals. So for this next poll, it's looking at these antipsychotics, atypical antipsychotics I've listed here. Which one do you think has the highest risk of extrapyramidal Parkinson's or inducing Parkinson's-like symptoms? So there's your olanzapine, the paliperidone, aripiprazole, and quetiapine are your choices. And we'll see what folks think in terms of the one that might have the highest risk of causing extrapyramidal or Parkinson's type symptoms. See what folks are thinking here. So in terms of extrapyramidal symptoms, it looks like it is mostly olanzapine that folks are concerned about with extrapyramidal symptoms. And certainly olanzapine can cause extrapyramidal symptoms. So of these, the next slide here, I've done sort of color-coded fashion, and the red being where you see the highest risk of extrapyramidal symptoms. Then the yellow is the ones with sort of moderate risk, and then the green ones where they have lowest risk of extrapyramidal symptoms. So olanzapine, we find it in sort of the medium risk. It's dose related, so at the higher doses, it probably would shift into the red, but in typical doses we use, it probably falls more into this middle category. So the ones I had listed earlier would be the paliperidone or Invega, right? I think that's the trade name for it, where it would be highest risk. So the paliperidone, the risperidone, most similar in terms of their action to the typical antipsychotic. So they closest sort of an action to something like the haloperidol or Haldol. So those are the highest risk ones. And then I'm not sure whether folks are familiar with loxapine in Sudbury Hospital. They use a lot of loxapine. So that can potentially have some extrapyramidal symptoms as well. So that's sort of that breakdown. And folks will have the copy of these slides, right? Kathy, I think they'll have access to that at some point.
They can reach out to me if they want a copy.
Okay. Yeah. And I'm fine with that if you want to have a copy of it. So that's that breakdown. So that's the extrapyramidal symptoms. And then the next slide is talking about the atypicals and anticholinergic side effects. So anticholinergic, so medications that are going to essentially affect memory and have a detrimental effect on memory. So I'm giving you the list of medications there. The olanzapine, aripiprazole, quetiapine, and risperidone. So which of them most likely would have anticholinergic properties that in somebody with a diagnosis of dementia, you'd probably want to use judiciously or carefully. So I'll give folks a little bit to respond, and then we can talk a bit about the anticholinergic side effects of the meds. Okay, so like a typing running away with it. Okay. Right. And folks are right. Quetiapine at a dose of over 100 milligrams, that's where you tend to run into more issues with the anticholinergic effects, and can be quite anticholinergic actually. It's interesting that after I did the first iteration of this talk, I went back and looked at a couple of resources, and depending where you look, often quetiapine and olanzapine flip-flop in terms of the reference, in terms of which one is more anticholinergic. So again, same setup, the red ones, highly anticholinergic, the ones in the middle, moderate, and then the lowest risk ones for anticholinergic properties in the green. So that's sort of your breakdown. And the key thing here, I think, is to remember that quetiapine. So obviously, a lot of folks already were aware of that. The quetiapine can be anti-cholinergic, especially at the higher doses. So that's anticholinergic. And then the last one, I just did a breakdown for folks as well, just in terms of sedation, because that's often another side effect we need to be aware of when we're using these medications in the elderly. And that's the breakdown there in terms of the atypicals that tend to be most sedating. I've just thrown Haldol, which is obviously a typical antipsychotic there, just as a reference for the other atypicals. So olanzapine, quetiapine tend to be the most sedating of the atypicals, and then risperidone, brexpiprazole, ziprasidone less so, and the aripiprazole actually can be quite activating. So in some people, you might not actually want them to be on the aripiprazole if you're concerned about it activating them too much. So that's in terms of the sedation side effects. And then to the finale, we'll look at sort of the approach and maybe a framework that you can take to sort of navigate the situation in somebody presenting with psychosis. I've never been sort of a big mnemonic type person, but in practice, you come across all these mnemonics all the time. I didn't find one for psychosis to the elderly, so I made up one. So I hope it makes some sense. We'll see. You can let me know whether it makes any sense at all. I'm talking about a precise approach to navigating somebody presenting with psychosis. So first of all, the P, we're looking at presentation. So how do they present? What are their symptoms? Some of those features we talked about when we went through the different diagnoses. And then it's important to review sort of their past history for any clinical clues, looking at health conditions, their medications. So take a deep dive that way. And then E's for the experience. How is it impacting the patient or client? How is it impacting their care partner? And we know the C talks about cognition, because we know the major neurocognitive disorders, dementias, are probably the conditions where we're most commonly going to come across somebody presenting with psychosis. So if you're able to get an idea of what their cognition is, their history of progression, maybe do the cognitive testing. And then investigations would speak to sort of that situation of ruling out a delirium. So doing your delirium workup, doing your examination, labs, imaging, anything that you feel might be indicated. And then the S for stopping and starting medications. Are there any medications or substances that are being used that might be precipitating, causing issues? And then based on the scenario, is it necessary to start one of the medications, whether it be an atypical antipsychotic, an antidepressant, or whatever, depending on the situation. So that's the S. And then E, obviously, if you're starting some type of intervention or treatment, you want to be able to evaluate how effective it is. So that's sort of the precise approach I came up with, and the mnemonic for what it's worth. It fit anyways, found letters to fit everything. Now, speaking about the approach and the appraisal, so if you do start some type of intervention, especially a medication treatment, titration, probably you want to do it conservatively every 1 to 2 weeks, making the adjustment, and then probably evaluating the response after 2 to 4 weeks to see whether what you've put in place has been effective, whether there needs to be any adjustments. In folks with dementia or major neurocognitive related psychosis, probably good practice, because they shift in terms of how they are from one stage, one moment to the next. It's probably good to reevaluate things in 3 to 4 months to see whether the treatment and intervention is still necessary. If not, and you want to reduce your medications, probably reducing the dose by 25 to 50% every 1 to 2 weeks is sort of a good way, a safe, conservative way to approach things. I've included at the end some of those evaluation tools, some of those screens that you could use to track psychosis and type symptoms. If folks were interested, I've sort of tacked that on at the end. And then I wanted to sort of bring things back to the cases we talked about at the outset. So this was the gentleman who was hearing the music and the German folk songs, and went to accusations and all that type of stuff. So he ended up being admitted to hospital. They confirmed the diagnosis of major neurocognitive disorder, Alzheimer's with psychosis. He was evaluated by geriatric psychiatry. They put him on risperidone, and I think they titrated him up to about 1.5 milligrams. That didn't seem to be effective, so they rotated him over to paliperidone. And I think he was on a dose of 6 milligrams twice a day or something like that, which is sort of a pretty robust dose. All the psychosis sort of resolved, and then it all settled, and he was discharged home, and I saw him back at the clinic. He had very apparent Parkinson's symptoms, so very apparent extrapyramidal symptoms. We ended up rotating him over to aripiprazole. Took us a little while to figure out the right dose, but he's the last time I saw him, I think it was within the last month or so, his status had sort of leveled off, where the psychotic features weren't there anymore, and the Parkinson's type symptoms were sort of minimized. So he was doing relatively well at that point. The second case was a gentleman with the Parkinson's disease, with the visual and auditory hallucinations and the delusions that sort of were becoming more distressing. So he ended up being admitted to hospital. I guess I wasn't doing a good job. My folks were ending up in hospital. So he ended up being admitted to hospital. And again, they said, yes, Parkinson's disease with major neurocognitive disorder. And they thought that his dosage of the levodopa carbidopa was actually too high, and probably making some of these hallucinations worse. So they tuned back his levodopa dose quite a bit. I think he went from 13 tabs in a day down to 6 tabs in a day. And they started him on a low dose of quetiapine, I think just at 25 milligrams at bedtime. And so he ended up back home as well. And when I saw him on the home visit follow-up, his Parkinson's symptoms actually had gotten a lot worse. And so it was very distressing to him that he wasn't able to mobilize as well. So we ended up tuning his Parkinson's meds back up a bit. And I think we settled on about 9, I think he's on a total of 9 tabs of levodopa carbidopa. At present, we've kept him on the quetiapine and tuned that dose up a little bit as well. And so striking a balance, he still has these visual hallucinations, these passage and presence type hallucinations, but they're not as distressing or upsetting now. So it's sort of from he and his wife's standpoint, they're sort of accepting of that trade-off of where things are at right now. And then the third case was the lady who had these delusions, didn't want healthcare providers involved, and was thinking delusions of theft, thinking people were stealing things from her. So she ended up in hospital too, but for a different reason, more for cardiac reasons. And so she was diagnosed actually with significant coronary artery disease. The cardiologist felt that she would be a good case to do actually angioplasty. She obviously declined all of the interventions. She didn't want anything done because she didn't trust any of them. So she ended up being managed medically. She was agreeable to take the cardiac medications that were prescribed. She was seen by geriatric psychiatry while she was in hospital. They felt that she had a minor neurocognitive disorder, maybe with a vascular etiology to it, and possibly mild behavioral impairment. So these change in behaviors and this complex of behaviors that might place her at increased risk of developing dementia down the road. And clearly with her mistrust of any of these medications, psychotropic, she's not on anything right now. I guess the only positive that's come out of this is that the last couple of times she's actually allowed us into the home to see her and haven't been turned away at the door. So I suppose that's a plus, moving in the right direction anyways. So that was that third case. So I figured I'd bookend the cases just to give a bit of closure to the cases. They're all still ongoing. And then just a couple of resources at the end. I've just listed a few resources, some good review articles that go through everything, probably more in depth and more clearly than I have today. So if you wanted to reference some of those, they're there for you. Yeah, and I've just listed a few more there. And for those of you who are familiar with the RX files, it's a great resource when it comes to medications and that, and I've listed a couple of the references for the RX files there for you as well. And then I had mentioned some of these scales that we'll sometimes use to evaluate psychosis and I've listed a few of them there. And then the modified Simpson-Angus scale is one that if you're into sort of using scales to monitor extrapyramidal symptoms, Parkinson's symptoms, that's one that you could consider using. Okay, and that's it. I'm done. And I think I did leave a few minutes, I think, for questions if folks had any or queries at all. So you can unmute and ask me, or you can throw it in the chat, however you want to do. Should I stop sharing, Kathy?
That's up to you. You can leave it up if you wish, just in case somebody wants to refer to a slide or.
Okay, I'll do that because I might not be able to successfully get back on again.
If anyone has any question, just unmute and ask.
Hi, Dr. Chow. I was actually just wondering if you know good referrals for geriatric psychiatry, actually, because I found it hard to get access to that specific specialty.
Yeah, that's a great question, Dr. Pritchard. So what we often do, we have the same issue in Sudbury and also in the Northeast region. So oftentimes what we'll do now is go through Geri MedRisk through e-consultation. And they do have a couple of geriatric psychiatrists, right, attached with their program. And so if you send them a referral through e-consult and put at the end query if it's possible to have a geriatric psychiatry direct, like a OTN or video consult, or whether they feel that's necessary, they'll actually look at that, and their geriatric psychiatrists are able to offer that service.
That's great. Thank you very much.
You're welcome.
There's one in the chat. Do you ever encounter issues around treatment decision due to altered cognition / capacity?
Yeah, that's a great question. And I think we often do come across that, where you're wondering whether a person's able to make those decisions themselves. And it's hard to say, right? Because especially in folks with cognitive impairment, sometimes it fluctuates. Sometimes in certain situations and certain decisions, they're probably able to still take the lead and make the choices. In other cases where there's going to be too many things for them to process, and it's not practical and possible for them to navigate. So I think it's a very individualized thing, and also sort of a situation by situation sort of scenario. A bit of a cop-out answer.
And just while we're waiting, there's a couple saying thank you. Thank you very much for this excellent presentation, and thank you.
And like I said to Kathy earlier, I'm happy to share the presentation with folks. So I guess they can email you, Kathy, and if they wanted a PDF copy of that, I'm happy to share that with folks.
Okay, I can do that. I know you have a couple of extra slides. Did you want to maybe chat about those?
Well, those are just going the right way. Yeah, these were just if you're ever wanted to and use something formally to track how effective your interventions are, these are some of the scales you can consider. They're not too difficult to use, like the brief psychiatric rating scale. I'm sure some folks are familiar with that. There's the NPI, the neuropsychiatric inventory, often used from the research standpoint, so not maybe the most practical thing clinically. I think some folks use the Kingston Standardized Behavioral Assessment in tracking behaviors in folks with dementia. So they do have a couple of subcategories where it captures some of these symptoms of psychosis. So it could be helpful from that standpoint in evaluating how effective your treatment is. And then the last one was just the Simpson-Angus scale, the SAS, which I had mentioned earlier, which is a useful tool if you're worried about somebody with Parkinson's disease, or you're using a medication or worried about them developing extrapyramidal symptoms. This is a good sort of objective way to sort of measure it. And in truth, I don't typically use any of these in practice, but I use some of the stuff from the Simpson-Angus scale in terms of side effects, just to capture the categories. It breaks it into how it's affecting their gait, rigidity, tremor, akaesthesia, restlessness. So I use some features of it, but I don't use the formal scale. So yeah, those were the thing, and that's embedded in the actual presentation I sent Kathy. So folks are interested in that. That's all there as well. So, okay.
I have one extra question, or maybe it's more just seeking commiseration, but most of my practice has been since the pandemic sort of started, and long-term care wait lists are so long, and I find a lot of my patients is sort of everything is taking so long that, and I don't really have very many tools, and then sometimes people are just basically presenting to hospital, and that's how they're getting admitted because of a crisis, but we can't place them beforehand. And I was just wondering, is this the way it's been for a while? Is this really since COVID? Has it been going this direction for, you know, a decade or longer, or what your thoughts are?
Yeah, I think it was already sort of a challenge, an issue before the pandemic. And I think the pandemic has made things that much more challenging because a lot of folks with the isolation and all of that, the support system sort of breaking down, a lot of folks sort of their conditions really deteriorated quite noticeably. So you ended up with a cohort of folks who were a lot sicker, their care needs were a lot more, and their usage of supports were a lot heavier, right? And so it already strained and overburdened system. And yeah, and unfortunately, there's no sort of quick solution or answer to that. I know born out of the pandemic, one of the things with behavioral supports is they got funded for transitional support workers, right? Transitioning folks from community hospital to nursing homes to smooth out that process. But that's sort of one little drop in the ocean of difficulties that we encounter in day-to-day practice. But no, for sure, Dr. Pritchard, that's an ongoing issue. And I don't think there's an easy answer solution to that. It's a system overhaul, I think.
Thank you very much.
Oh, yeah, and I should mention for those folks who aren't aware, Liz Byrne now is our clinician who's locally now embedded there in Parry Sound at the hospital. So we're actually fortunate to have Liz on board, and it's great to have boots on the ground all the time now, instead of me parachuting in every couple of months, sort of thing. So we're hoping that we can maybe ramp up what we're able to provide and support to the West Parry Sound and the surrounding area. So we can hope it is.
Okay, I'm not seeing anyone else popping up. So thank you very much. As always, Dr. Chow, it's always a pleasure working with you. And just so that everyone knows, our next Zoom rounds will be January 25th, and it will be the Regional Sexual Assault and Domestic Violence Treatment Center out of Aurelia that will be presenting. Otherwise, everyone have a very lovely holiday season, and we'll see everyone in the new year.
Hi, thanks.